Good afternoon, everybody. Thank you very much for joining us here today at Healthmonics as we go over the 2023 PFS Final Rule. We'll be going over eCQM's MIPS CQM reporting and why it's here to stay in ACOs. We will be doing a follow-up webinar next week in regards to the MIPS side of the business. So if you're interested in the MIPS side, make sure that you sign up for the traditional MIPS program that we will be putting out next week. This is going to be an ACO specific review of the final rule that was released last week. Today, I am joined by Steve Tyson. Hi, Steve.
Hello.
He and I will go over the slide deck throughout the entire hour that we have here, and maybe a little bit less time, but we'll see. Hopefully we have an opportunity to answer some questions at some point today. Just for navigation purposes, you can see on the right-hand side of your screen an area for questions. You could ask any questions over there on the right-hand side. If we can't get back to you during the presentation or at the end of today's presentation, we will be able to respond to you by the end of this week via email. So please ask your questions, as many as you would like. If you'd like to download the slides, you can see that also under handouts. Currently, there is one handout in the section, and that is the slide deck. At the end of today's meeting webinar, I will be giving out a link to this video as well as a link to those slides. So you'll receive everything in an email shortly after today's call. So I'm going to turn it over to Steve to get us started. We're going to do a little back and forth. And thank you once again for joining us. All right, all you, Steve.
Thanks, Mike. Appreciate the introduction, and good afternoon, everybody. So far today, we'll review as a recap of the 2023 final rule for ACOs, what that specifically means and how that impacts your accountable care organization, and how we as Healthmonics can help you achieve your goals and your reporting goals through it. So CMS's objectives for ACOs in 2023, there are many of them, but a few that we will highlight within this webinar on this slide is CMS is actively seeking processes to make healthcare more equitable across the entire U.S. population. The goal is to have 100% of original Medicare in relationship with accountability for quality and total cost of care by 2030. And what ACOs are, what CMS is adequately and actively doing is incentivizing ACOs to provide high quality care to underserved populations within their population and within their ACO to allow, and as Mike will go touch into more, health equity. What CMS does not want to do is create an incentive for ACOs to avoid underserved populations as they continue to transition to the eCQM MIPS CQM, as that's coming down the pathway, and they want ACOs to start serving the underserved population and not delay transitioning in that transition to the eCQM MIPS CQM model, or even possibly even shutting down their accountable care organization. And what they want to do ultimately is to work more closely with the low revenue organizations to allow them to participate, fully invest in their care and quality improvement to allow them to continue to see shared savings. Just a little bit of background statistics as of January 1st, 2022. It's hard to believe that we're heading to 2023 soon here. For the MSSP program, ACOs provided 11 million people with Medicare. 528,966 healthcare providers participated, which is a huge number, and also a very huge staggering number. 483 participating ACOs that participated within the program. So a little bit of a highlight with the final rules, with the final rule coming out and the changes for ACOs that's coming. We have a new finalized sliding scale for ACOs that do not meet the quality performance standard. Mike will go into a more depth and detail later within this webinar, but the health equity adjustment to reward ACOs for transitioning to the all-payer model, the eCQM, MIPS CQM model, and surveying a high proportion of underserved beneficiaries through it. Requirements also transitioning to the eCQM, MIPS CQM model. They're also planning to extend the incentive for reporting the same model through 2024, finalizing the benchmark policies as well. And then with the addition to a new CAPS survey. And then increasing, obviously, importantly, increasing participation in the accountable care models that they lay out to underserved communities and providing an option for incentive payments for certain ACOs that need to meet that.
So I'll take back over here. We're going to go through eCQM, MIPS CQM reporting and what the path looks like to go there. CMS has defined the scaled approach to transitioning eCQM, CQM reporting. We're going to go over that on the next couple of slides here. They are continuing the incentives that they have laid out for 2023 into 2024. They have said that they're aligning with the sunsetting of the CMS web interface. There's been no change to that, and the CMS web interface will go away after the 2024 reporting year. And then they're going to provide 1 additional year to gauge performance prior to the full reporting requirement in 2025. So in 2023, and we'll go over this a little bit more in detail and then give you some ideas of what it looks like to ramp up and work with an organization like HealthMonix to get where you need to go with the APP reporting requirements. So first off, in 2023, you can report your 10 web interface measures or the 3 eCQMs. So you have an option there. You need to administer a CAPS for MIPS survey, and then CMS will calculate the 2 claims-based measures that are there. And then you must complete one of the following 3 in 2023, achieve a health equity adjusted score of higher than the 30th percentile. So that is overall, your overall score for MIPS quality. Report 3 eCQMs, MIPS CQMs meeting the data completeness and case minimum requirement for all 3. So you need to meet the requirement, which is 20 patients, which I believe every ACO I know will be able to do that. And achieve a score in the 10th percentile for at least one of the outcome measures and the 30th percentile on one of the remaining 5 measures. So those are the benchmarks for the MIPS measures that they're talking about there. Or they are, and this is the newer part, if an ACO fails to meet either of the 2 options above, but meets the alternative quality performance standard with a score of 10 in the 10th percentile on at least one outcome measure, and you will see later that there are 4 of those, they can share in savings at a lower scaled rate. So you'll see that there's a little bit of a scaled rate, which we will go over in a couple. The change for 2024, however, it hasn't changed since the proposed rule. But if you take a look at it, the one big change here is that everything jumps to the 40th percentile. So that 40th percentile in 2024, that's for the overall MIPS scoring. And then you see for the individual measures, you also need to be in the 40th percentile for one of the 5 remaining measures and the 10th percentile. But the same rules apply in 2024, except for the little increase from the 30th percentile to the 40th percentile. And then when CMS web interface is no longer in 2025, you'll see that the only option you have up at the top is the ACOs required those 3 eCQM, MIPS CQM measures. The same thing for the CAPS survey and the 2 claims-based measures. And then there is no option for the 10% and 30% or 40% at the bottom. You need to achieve a health equity adjusted quality score equal to higher than 40th percentile, or you need to meet the 10th percentile on at least one of the outcome measures, which is going to help relieve some of that pain, and you will get paid a lower amount in the shared savings and or in the shared losses. The important thing here to understand is that that 40th percentile is going to be very high, and it's a combination of all of the ACOs out there and ranking for that. That number is not known now. That number is known after the reporting period is over. So you need to perform very, very well during the year. Last and not least, for all 3 years and moving forward for 2025 and beyond, you will not, if you don't report 10 CMS web interface measures or the 3 eCQMs and administer a CAP survey, you will not meet the quality performance standard and you will be penalized at the fullest extent. If you, for the second part for 2025, if you do not do the 3 eCQM, MIPS CQMs and administer a CAP survey, obviously since CMS does the claims based, they're not included in this, but you will not meet the quality performance standard and you will be penalized to the fullest extent. I'm going to throw it back over to Steve as he goes over the measures before I get into a little more about health equity.
Thank you, Mike. So this is a little bit of a high-level rundown of what the measures look like for the APP reporting measure set. This is taken from the final rule. A couple things I want to highlight here. First is the outcome measures, and as you can see through the screen here, and needing to score in the 10th percentile on at least one of them for in the next 2 years. As you'll see here, you have the CAPS survey for MIPS, which is also a very important part of this process, and then you have the 3 eCQM measures that have not changed, that are still here, and that are needing to report on. And then some of the potential new measures that are coming here. Here's a high-level rundown of screening for social drivers of health. You'll see a nice little definition here, percentage at which providers screen their adult patient, food insecurity, housing instability, transportation problems, and just overall, and being able to screen for them at the time of care, and then screening for positive rate for social drivers as health, percentage of patients who screened positive for health related needs. Something that I do want to highlight here is at the bottom of it, the 84% of the physician offices that do not screen all the 5 needs. Found that very interesting, and this is something that CMS is really starting to drive home within the final rule and just in their communication is health equity. These 2 potential measures, scream at me, scream at a lot of people for health equity and needing to, step up the game, step up to the plate, and start providing care to all populations within your accountable care organization. Throw it back over to Mike for a very in-depth rundown of health equity, what that looks like.
Sure. So we're going to go over in here how the health equity adjustment has been finalized for 2023 reporting and 2024 reporting. Moving forward, they plan on making some adjustments, as you can see by the previous page, with some different measures they plan on adding, and they're always looking for feedback from the ACOs on how to better help with the health equity. So some of the important things is that ACOs are inequitable, and that prior to that, because of the reporting through the web interface, is only Medicare patients, and that does not see the big population of the poor and underserved in the United States. Minority populations are not represented equally in current ACO patient populations, and that includes Black, Hispanic, Asian Pacific, Islander, Native American, Alaska Native are less likely to be assigned to an MSSP ACO. And there are many reasons behind that, some from the ACO side, some from the areas they live in, the rural areas of the United States as well. ACOs are currently not focused on expanding the rural and underserved populations in communities. They're still learning the ropes of what needs to be done with their own communities that they currently have, and CMS wants them to start expanding right away. Per the Office of the Assistant Secretary for Planning and Education, dual enrollment status is a strong indicator, predictor of poorer health. So those that are both on Medicare and Medicaid, so your older population and your poorer populations together, that is a strong indicator that they are not seeing the same results in healthcare. Research studies demonstrate that neighborhood level factors for those residing in disadvantaged neighborhoods also have a relationship to worse health outcomes, whether that's through education or access to healthcare, access to professionals, understanding what they can and can't get based upon the insurance that they have. And the other one is living in an area with an ADI score of 85 or above is shown to be a predictor of multiple things, including 30-day remissions, lower rates of cancer survival, poor end-of-life care with patients with heart failure, and longer lengths of stay and fewer home discharge post-knee surgery is what they used. So there is a lot going on there with the ADI score, and that's how the score will be adjusted moving forward, and we're going to get into that now. So introducing health equity adjustment, that's going to start in 2023. It is only available for those ACOs that are reporting the 3 eCQM, MIPS CQM. They need to meet the complete data completeness, administer the CAHPS MIPS survey, and they may receive up to a maximum of 10 additional points to their quality score. And we'll go step by step here to show you what that score looks like on the following slides. The level of adjustment will be based on measure performance, so the combination of measure performance and the proportion of beneficiaries who are from underserved neighborhoods who are duly eligible for Medicare and Medicaid. It's an or, so it's either one, and I'll show you what that looks like. Higher positive adjustments to ACOs providing higher quality of care to underserved populations, with the amount of the adjustment increasing as an ACO's proportion of underserved beneficiaries increase. They're going to limit the adjustment to those that are just doing the eCQMs and the MIPS CQMs, which is one going to further encourage ACOs to change over to the eCQMs, and also it is really to combat some of the changes in the additional patients that will be falling into the quality categories for each of the measures. Those ACOs with an underserved population less than 20% are not going to be eligible for the bonus, but they are also not penalized. So this is just a bonus. This is not a carrot and a stick type situation. And there's approximately 30% of the ACOs in 2021 that would not have been above the 20% threshold. So one thing, considering the impact of Medicaid enrollees in ACOs, the concern that the ACOs with higher Medicaid enrollees will score lower due to the switch, because now they're included in all of their quality categories. And the concern that ACOs with the Medicaid will delay switching to eCQM, MIPS CQMs, or even drop out together. We mentioned that earlier. But that is a true concern of CMS, is that they don't want to punish ACOs for taking on these populations. They want to incentivize them for taking on these populations. So how does it work? CMS will assign a value for each of the 6 quality measures and the corresponding performance group. You have a 4 for the top performers, a 2 for the middle performers, and 0 for the bottom performers. And we have a slide coming up that's going to show you that in graph form. CMS will add the values for each one of these 6 measures and assign what's called a measure performance scalar. The scores will range from 0 to 24. They will receive a 0 score if they do not meet the case minimum requirements for the CQM, eCQMs, or the CAHPS for MIPS surveys. The maximum bonus points is 10, will be rewarded to their MIPS quality score, with a maximum MIPS quality category score of 100. So nobody's going to get 105 on their scores. So step 1, determining your performance group. Here, this is straight from the final rule example. we have 6 different ACOs and showing them each of the 2 combos, 1, 2, 3, 4, and 5, 6, and what their scores would be. You can see each one of the measures scores down the value line, and then the total assigned value per ACO. As you can see, the highest ones are going to be 24 points. The middle group there is at 18, and the lower group there is at 6. Step 2 is to determine the underserved multiplier. So for this, there's 3 factors being used to reflect different types of characteristics and are influenced by different patient populations. ADI national rank is based on 17 input variables from census data, things like education, income, employment, housing, and household characteristics. You have the dual Medicare and Medicaid eligibility. That is a direct measure of the beneficiary that reflects their individual. So the first one is neighborhoods, right? It's done by a neighborhood. The dual Medicare and Medicaid is going to give you specific information of an individual. And then on top of that, there's also the LIS and the national measure and capturing individuals who are receiving Part D. So those patients that are receiving Part D care, that is going to be in turn counted with the dual Medicare and Medicaid eligibility. There is some overlap as expected, but instead of multiplying them together or adding them together, you're actually going to be given the top one of the 2 scores, so that duplication is not in there. The underserved multiplier will be determined based on the higher of the 2 numbers. Just said that. All right. Here's an example of what that looks like. You can see in the left column, that's the proportion of assigned beneficiaries with an ADI national percentile rank of at least 85. Then we have in the second column, those are the beneficiaries that are dually eligible, or their ADI is going to be higher. And then what they do, as you can see here, is they're not multiplying them. They're taking which one is the higher, and that is what your underserved multiplier will be. Next is step 3, the calculation of health equity adjustment. So what they do here is you have each one of the ACOs listed on the left-hand side of the screen. We have your measure performance scaler, that was from step 1. You have your underserved multiplier from step 2 that are multiplied together to give you your health equity adjustment bonus score. As you can see, group number 4 had an underserved multiplier less than 2. Therefore, theirs does not count, and they do not have a health equity adjustment bonus score. But ACO number 1 had a perfect measure score along with a perfect very high underserved multiplier, and they're maxed out at 10 because 10 is the highest that you can get. All right, and then the final step is to compute your final quality score. For here, what we have is we have your MIPS quality score on the left column. Then you have your health equity adjustment, multiply those, add those together, and that will give you your health equity adjusted quality performance score. As you can see, the highest you can get is a 100, but you can also see that these scores are going to help people who may have been penalized to get out of the penalty range and to share in the incentive. So there are some concerns that CMS has with the health equity, and that's why they are always open for suggestions and comments on it. But the main things is masking the real differences in quality. So instead, this is obviously not, we used to call it click quality, but it's how well do you answer these questions, these MIPS questions, and does it really, how big is that impact on the actual care the doctor or the other clinician is providing? Identifying and addressing real disparities, are they able to do that, or does this cover up some of those? And then the last thing, which I find the most interesting, is setting lower standards for underserved populations. By doing some of the options that they were thinking about for this program, one of their concerns was that those patients that were in underserved populations would be really have these lower standards. Like they can have their diabetes numbers a little worse off than someone in a higher, in a different type of population. And that was a big concern of them. So instead of modifying their current quality performance requirements for ACOs, CMS wants to adopt an approach that rewards high quality performance across all populations, not just those that are in Medicare ACOs. And then the last one here, ACOs that report both eCQM measure set and the web interface will be assigned the higher of the two scores. So this is important to get. CMS will calculate the eCQM MIPS CQM score after the health equity bonus, right? And then compare that to the web interface. So since the health equity bonus is included in the web interface, that extra bonus points will be added to their score on the CQM side and not to their web interface. And then MIPS eligible clinicians' final scores are not adjusted to the health equity because the health equity adjustment is currently only available in the shared savings program. Before I pass it on to Steve, as he's going to go through the all or nothing scoring, I do want to share this is a great time to get your questions in. If we do have the opportunity to answer some questions, we will, but there is still a lot of more information to share with you. Does Miggy got it or you got it?
I believe I have it for a little bit. Through the final rule, something that was finalized is the all or nothing scoring. A little bit of a rundown of what this looks like and what CMS has decided to finalize is that, the CMS is concerned that the all or nothing approach to scoring may make some ACOs or a decent sized population of ACOs ineligible to see shared savings due to some minor differences between the MIPS quality performance and the quality performance standard. But what this is going to allow ACO to do that are close but did not really meet the minimum requirements is still see the share savings, maybe in a little bit of a lower threshold, but still to see those savings, which is very important to all organizations. And then also with this approach, will provide ACOs higher rewards that allow them to invest in the infrastructure needed to move towards the eCQM and MIPS CQM reporting. What I really want to point out is the word infrastructure and being able to invest in a strategy and being able to, whether it's employees or just all across the board, the infrastructure that is needed to allow them to start making that transition to the eCQM, MIPS CQM reporting side. Being able to adopt the sliding scale approach for ACOs and MIPS quality performance, it helps combat the performance benchmarks, which is important, and calculated for 2 outcome-based administrative claims measures where benchmarks will not be known in advance. Something else to highlight here is the sliding scale approach will be adopted by all ACOs, regardless if they decide to report the quality of data. What that looks like is obviously through the eCQM, MIPS CQM transition, and also CMS web interface as well. And then very important to understand the ACOs in the enhanced track will benefit from the sliding scale. Shared losses will go from all or nothing to 75%, between 40 and 75%, which is a very good cushion sliding scale for those that fail to meet that standard of quality performance or at the 10th percentile on one of the 4 outcome measures. Very important to understand, to comprehend, and to be able to execute as well. And I'm going to flip it over to Mike to give a little bit more of in-depth math analysis of what this looks like.
All right. So for that, the ACO Health Equity Adjusted Quality Performance Score, this is an example of what it can look like, is 45. So that's all the health equity stuff that we just talked about with their final score, which is less than the 30th percentile. So just remember, percentile and score are very different. The ACO achieved the quality score at or higher than the 10th percentile. So they meet that 3rd option down the bottom that I showed you on the previous slides. And then the ACO is on a level B of basic track, has a maximum shared saving rate of 40%. This example is taken directly from the final rule. So you take the 45% score for the ACO health equity adjusted performance, and then you have the 40% for the basic track maximum sharing rate, and then you multiply those together to give you the 18%. So 18% times the total ACO total savings is what you will get. Obviously, you can see it's a far drastic lower number than what you would have received if you met the 30th percentile, but instead of penalizing you fully, it allows you to have a little bit of a cushion for your score.
Okay, thank you, Mike, for that. And then a few takeaways that we have, Mike and I, through our research on the final rule and reading and going through it, is CMS is going to show the calculation of the adjustment for all ACOs that report the eCQM and MIPS CQM model, even if it would not affect their shared savings or losses. So that's a very good way to see that and that data. Every year, more ACOs are starting to implement the eCQM, MIPS CQM reporting. And CMS is going to allow you to utilize these submissions to make refinements and to be able to take a look at your data, to take a look at what your changes need to be made and what where you can improve and performance enhancement as well. And then also, last but not least, looking for alternative methodologies to calculating the underserved multipliers. So determining your strategy. Mike and I are very big sports fans, so I was going to start off here with a sports analogy to really hit home of what your strategy can look like. So we're big NFL football fans, and sorry to those who may not be sports fans, but each team goes through a preseason, 3 preseason games to really take a look at your team, your strategy, what your team looks like, the game plan, and then also your infrastructure, your coaches, your whole team, and really go through it and determining your strategy. And this is how we really look at it here at Healthmonics, is being able to use that ramp up time 2023, 2024 to really start looking at your data, being able to track both the MIPS CQM measures alongside with the web interface measures, and being able to take a look at that data, to see where you stand really. This allows you to partner with your providers and groups to change workflows to capture the quality measured data, and then also important to start tracking the eCQMs as you're moving into 2024 and take advantage of better benchmarks, and then obviously to be fully prepared when the program gets harder. So being able to determine a game plan in these 2 years, to look at your strategy, your infrastructure, and how you can make yourself even more successful as you begin the transition is very imperative. Using experts to work with quality measure to help you navigate through the changes, the obstacles. It's going to be a bumpy start to start off with, because this is a big transition and change. So being able to see your data and being able to combine from different EHRs and healthcare technologies is imperative. Tracking your data all year long to take a look at performance improvement, where providers could be potentially missing documentation, and being able to work through that as you have those ramp up times, and being able to obviously take a look at your data, attack your gaps in care as well. This is a timeline that we encourage, and this is a timeline that we've worked through with our organizations. It's in 2023, really identifying all your data sources, the EMRs that you're looking at, EHRs, being able to see where all that data is coming in, and being able to take a look at that at one platform, and to be able to analyze and start formulating that strategy and game plan, designing a integration process, being able to bring your data in from different systems. Also being able to track the CQMs, report the CQMs and the web interface at the same time, and be able to take a look at that data side by side is very important. And then obviously working with your clinicians to improve your scores, documentation as well. That's something that we really encourage, and being able to use that ramp up time to your advantage. Using that to your advantage is going to be able to make you more successful as this programs get harder and that transition. As you'll take a look here in 2024, obviously it's still working with your clinicians to document measures, to count the eCQMs, continue to refine your data integration, whether you're bringing in that through different sources and how you're bringing that over, identifying gaps in care, and then start tracking the eCQMs and take advantage of the better benchmarks as well, and utilizing the data for non-MIPS related quality tracking. And then in 2025, when this is official and it is, you're starting to track the eCQMs, fully embrace the tracking. You've used those previous 2 years to really gain your insight and your knowledge in your organization of where you need to improve, where you can get better, and you use those 2 years to really determine your strategy. And now you're into the regular season where you're playing all year round and you're fully embraced the tracking of the eCQM model, and continue to obviously drive performance improvement and healthcare as well through your population. So, $1 million question: how can you successfully track and drive your eCQM, MIPS CQM performance? Using a partner like HealthMonix, us, to really partner with you side by side to help you through that whole process. Through our APP Impact, we're the most trusted name in quality reporting, delivering higher reimbursements than MIPS, APMs, and ACOs that we are working with to be able to monitor their full performance. How will we impact your analytics and help with your performance? We maximize your performance, looking at your data all in that one area, identifying areas of success and improvement opportunities, and you'll be working with a team here throughout the whole year, being able to take a look at that data, to drill down, to be able to help you as you make that transition to 2025, where you're tracking the eCQMs, drilling the root causes, the performance gaps, to allow you to minimize those, and to allow you to take a look at your performance overall, and being able to go back and take a look at that. Obviously holistic, transparent view of quality for your entire organization across the board, and a comparative view, being able to take a look at your scores, maybe across locations, different patient populations, insurances, being able to see your data in real live time, and being able to make real meaningful impact changes to your organization as well. This is a little insight of what it looks like to work within our platform as well when you're tracking the eCQM, MIPS CQM performance. Gives you a nice little rundown of the measures that you're tracking, where you are exactly in your organization on the measures as you're bringing the data over to us as a partner, measuring your performance. You're going to have that national average comparison, which is very important to be able to see where you are in your peers, and then your provider and patient visit counts, and being able to take a look at your data on provider, at the patient level, at the location level as well. That's something that we provide to you in order to allow you to take a look at all that data on one subset. We also give you the ability to track your web interface measures as well. It's very important. Obviously, with the web interface for the next 2 years, you're going to be able to take a look at the web interface measures along with your eCQM, MIPS CQM measures as well, and being able to do that. The CMS is going to be able to, not CMS, we'll be able to give you that data, and as you're bringing that over to us, and being able to take a look at your performance and data to real time, and being able to see how you're performing on the eCQM side versus the web interface side, and being able to use that opportunity in that ramp up measure time to be able to give you that performance where you need to be on the eCQM, MIPS CQM side. And then a provider overview as well, being able to take a look at performance by provider, which is very, very important. Obviously with the number of eligible instances as well, as you're able to take a look at your provider, this allows you on the performance time period to start working with your providers and how they're documenting, how they're bringing the data over. That way we can partner with you to help you in that transition as you begin to transition to the eCQM model, in terms of giving you opportunities to work with your providers and how they work with us and you to help with the data performance. And health equity. Mike did an awesome job and really given a great definition and great just rundown of what that looks like. Health equity is a huge aspect that CMS is pushing and is really honing in on, and we're here to help you in the health equity realm and being able to give you a breakdown by including race, ethnicity, zip code, geolocation, giving you access to certain populations that need quality measures more than specifically addressed. Health equity is here to stay. It's only going to get bigger, and then being able to take a look at that within your organization is only going to help you even more. We're going to be able to give you all that information and data, and then more. And then it's also, as Mike hit home on, is that it's going to help you in terms of incentivizing with the health equity adjustment as well. And it's something that we're going to be able to help you out with and be able to partner and help you down the line in terms of when you're looking at your health equity adjustment. And then just a little announcement, stay tuned. The next webinar is coming in November as well, and I think Mike hit on that as well.
Yeah, we'll be doing a number of webinars coming up. The next one will be on the final rule from a MIPS perspective, as well as we have some partner webinars that we'll be headed into in November and December. So stay attached to our sites and emails for those communications in the near future. This is the contact information for Steve and I. We are in charge here of the ACO side of the business. So if you have questions or concerns or want to reach out to see how we can work with you, please feel free to reach out to us. We did not receive many questions today. Most of them were specific about their practices or ACOs. So I will handle those offline. You have a minute or two if you want to get a question. Otherwise, I want everybody to enjoy the rest of the week, and we look forward to working with you in the near future to meet all of your quality goals. Thank you very much, and see you soon.
Thank you very much. Appreciate it.